So thank you to everyone who's joined us this evening. It's great to see that we've got quite a few people with us tonight for our session on glaucoma surgery. Tonight we're joined by David Lunt, who is a consultant ophthalmologist and a specialist in glaucoma from South Tees NHS Foundation Trust. Those of you who joined us for the dry eye session back in September will recognise David, so he's come back again, which we're very grateful for. So I just want to tell you a little bit about Glaucoma UK before we get going. So Glaucoma UK is the charity for people with glaucoma, and we work in three main areas to prevent sight loss. Firstly, we campaign to raise awareness about the disease. We want people to know what glaucoma is and how important it is to go and get your eyes tested regularly, because the earlier glaucoma is diagnosed, the less likely people are to lose their sight from it. Secondly, we provide support and advice for people who live with glaucoma and those people who care for them. We have a range of services, including leaflets, a helpline, a buddy service. We have a patient forum, and we also provide training for professionals who look after people with glaucoma, and all of our services are for free. And finally, we fund research into the diagnosis, treatment, care and prevention of glaucoma. It's not a huge amount of money, but we often provide initial funding for blue sky research that gets early stage research going. And we're funded by the generosity of our members and our supporters. So now what I'm going to do is stop sharing my screen, and I'm going to hand over to David for the main part of this evening.
Okay, so welcome everyone. I'm just going to share my screen and get the presentation open. And then we can get going. So thanks for the introduction, Hannah. I really enjoyed these talks, and I think it's the third time I've spoken on behalf of Glaucoma UK now, or then IGA, and I'm really pleased to have the opportunity to talk about glaucoma surgery, because most glaucoma specialists, that's the thing that they're most enthusiastic about, I suppose. And my other passion is communication and kind of mutual decision making about care. So hopefully, you know, having a little bit more information about some of the details today will help some of you, and we'll try and answer as many questions as we can as well at the end. So typically when I'm in clinic, these are the sorts of questions that patients come up with. And I will look at I'll look at all of these later and answer these. But first of all, I'll just give you an outline of how the talk will be split. It'll be split into two halves. Firstly, just going through some basics. I think it's really, although for some people, as soon as I get a picture of the eye out, it immediately worries them in terms of just being able to understand things. I think it's really important to a certain extent to understand glaucoma, and I think of it in quite simplistic terms, and I'll go through that with you a little bit later, because it's important when your specialist is thinking about different treatment options, to know a little bit about the anatomy. You know, there's lots of new treatments that are published in various papers, and a lot of patients bring these things, and if I'm saying yes, I will do this because, or no, I won't do this because, it's good to kind of know a little bit about how the eye works. The second half will be just going through all of the different surgical treatment options, and I'll also touch on laser a little bit as well. So at its simplest form, the eye is an simple internal plumbing system. So this, importantly, the first point about this is that it's separate to the tear system. So dry eyes, tears, watery eyes, that's completely separate. So what I'm talking about is an internal fluid system that keeps the eye inflated. And there's a part of the eye or the tap that slowly trickles water into the eye, and there's a drainage network as well, which slowly moves water out of the eye. And this needs to be in fairly perfect balance to maintain the pressure in the eye. So what we have, the picture on the left there is just my kind of scribble drawing of how the front of the eye looks face on. And the picture on the right hand side is a cross section. So as if we've cut directly through the center of the eye vertically, this is what the eye looks like. And I'll expand on this a little bit now, and I'll make it just a little bit simpler. Essentially, there's three parts of the eye that we're going to be talking about. From right to left, the optic nerve at the back of the eye. And you will see that yellow optic nerve extends to inside the eye and forms the initial part of the nerve network in the retina. The back half of the eye is filled with a fairly solid gel, and that has little input in development or changes in glaucoma. What I will spend some more time on, though, is the front cavity of the eye, which is filled with water-like fluid, watery liquid that carries nutrients and is in constant circulation. So again, just taking it slightly simpler, there are those three areas there. So the simple model of glaucoma: water builds up in the front half and can't escape. That force is then transmitted backwards through the gel towards the back of the eye. The structures of the eye in an adult are quite stiff and they don't stretch. So what happens in this case is the pressure builds up and the weakest point gives way, and the weakest point happens to be where the nerve enters the eye at the back there. Then what happens is the nerve gets compressed specifically in this location. And also the second thing is that the nerve gets pushed backwards a little bit as well. So taking that, looking at what your ophthalmologist will see when he looks at your eyes down the microscope, we can see two eyes here. The one on the left is healthy, and the one on the right has glaucoma. So the first thing that we look at is the outside circle here, which in both of these eyes is more or less the same. The second thing that we often look at is the inner circle here, highlighted by the purple rings. And the in between the purple ring and the green ring is the healthy nerve tissue. And if we look at the similar sort of area in the right eye, there is loss of that nerve tissue. And again, I'll just remove those circles so you can get a little appreciation of that as well. So how does that affect function? So in this optic nerve, at the top half, you can hopefully see that there's a slightly darker color, which represents that the nerve is thick there. And at the bottom, that's outlined by the red dotted circle, there is marked loss of the nerve. So because the image is flipped in the eye, this corresponds to this black area at the top half of the vision. Now, the picture on the right-hand side, the grayscale image, is similar to a map that's printed out when your specialist requests a visual field test. If you've never seen a picture like this, I would ask your specialist next time, because this is something that I use all of the time to try and explain how glaucoma damage is occurring and is progressing, because this patient is probably asymptomatic, and I may well be listing them for a trabeculectomy or another type of operation, and I need to explain why that's the case. So I'll talk a bit now about aqueous dynamics. So aqueous is the other term for the water fluid at the front part of the eye. And to do this, I'll just rotate the eye in this direction, and I'll expand it and look at the left half structure. So what I'll do for the next 30 seconds to a minute is just go over the pathway of the fluid flow inside your eye. I apologize that this is getting a little bit complex now, but I think it's very important in terms of understanding how laser works and in terms of understanding how certain types of surgery work. I won't dwell too much on it though. So first of all, there's a structure just behind the iris called the ciliary process. And that's the structure that is the tap that slowly trickles water into the eye. And that stays more or less at the same rate during the day and night, and more or less the same rate throughout life. If anything, it reduces slightly as you age. Secondly, you can see by those yellow arrows, the water fluid traverses the pupil and goes into the very front anterior chamber. Then this travels across to the very start of the drainage meshwork. And it's a very tight, multi-layered meshwork that very slowly trickles the fluid out. It's generally accepted that, and generally found in experimental studies, that this trabecular meshwork and the tissues just beyond there is the main point of resistance for flow of the fluid. So what happens with age and what happens with development of glaucoma is this meshwork thickens slightly, stiffens slightly, and just functions slightly less well. So the amount of fluid that escapes the eye reduces. The next from there is it traverses into a canal, and I'll show you some further images of that in a second. And following on from there, ultimately it exits the eye through the venous system, so it becomes part of the blood vessels in it and into the veins, and it circulates around. The fluid in the front part of the eye is essentially super filtered down blood. It's filtered down to the extent that the red blood cells are no longer there, because then we can see through that. Okay, so this green ring, this is slight artist's impression because it is not in proportion that large. This green ring is the Schlemm's canal, so it's almost like a big drain pipe that's just beyond that trabecular meshwork that the fluid flows into first, and then into this array, this network of blood vessels before it goes into the veins and then gets pumped back around the body. This is slightly more complex, but a slightly truer picture, and you can see that this that the Schlemm's canal ring is kind of sausage shaped, so there's bends and kinks and little diversions here and there. So whilst I said that it's often the meshwork that's the main resistance, there can be resistance here, there can be resistance at the next part, and one of the other resistances to reducing the pressure to a huge level is the venous blood pressure itself. So that's one of the main reasons why lots of people, the eye drops can only go so far, because there is a back pressure from your blood pressure, and that's normally a lot of people, the first time I meet them, they say, well, I've got high blood pressure or low blood pressure, is that relevant for glaucoma? Generally not. Low blood pressure typically is worse because that can result in poorer blood flow to the optic nerve, but generally the blood pressure, it can limit how low the eye pressure can go, but it's not hugely involved in an interactive way. So it's not as if you have high blood pressure treated, it will make a difference to the eye pressure. So why do we do glaucoma surgery? So what glaucoma surgery does is increases the outflow. We're not in an era, unfortunately, of medical technology where we can really improve anything. My job is to help people retain what they have in terms of the vision. So if we can, and we can only really do that by lowering the eye pressure, and almost every laser or surgical procedure increases the outflow as opposed to affecting the inflow. Now, some of the drops affect the inflow, and some of the laser procedures affect the inflow, which I'll talk about a bit more in a second. But in general, what we're doing is we're improving the drainage that is resistant and blocked in a way. This then lowers the eye pressure, which reduces the pressure on the optic nerve, which can slow glaucoma progression, which enables people to retain as much vision for as long as possible. And as Hannah alluded to before, the earlier it's diagnosed, typically the better it is in terms of a visual prognosis for people. What surgery does not do is it does not cure glaucoma. It can only slow it down to as slow as possible, knowing that there is also an age-related decline in the optic nerve. It also does not restore any lost vision, although some people can have a mild improvement in vision. So I'll talk a little bit now specifically about some of the types of surgery. And I will start by laser because although it's a procedure, I don't view that the same as some of the surgical techniques. There's lots and lots and lots and lots of different types of laser that we use as eye specialists, and we're lucky that we're in an era of medical technology in this regard where we can do things where previously treatments did not exist. So I've just categorized these types of laser into those types of laser that you might have in the clinic setting and those types of laser that you might have in theatre. So in the outpatient clinic, some of you may have had or may have read about a procedure called SLT, or selective laser trabeculoplasty. And what SLT does is, using a very, very, very low powered laser, is across the trabecular meshwork, as seen by the green circles there. It gently stimulates the cells that work in that area. Previous iterations of this, called argon laser trabeculoplasty, used to blast little holes through the trabecular meshwork, which would then scar and stretch, and that's how it would lower pressure. But this form is much less interventional. The side effects are fewer, and it tends to be very good. So it's best for people who've never had treatment before, but often it's used if people are on 1 or 2 drops, or I sometimes use it if I'm trying to get someone a few units lower. It tends to be at best as effective as adding in an extra eye drop. So it doesn't normally mean that people can stop taking the drops. It's just as if we've added in another drop, but it can be repeated and it's safe. And yeah, I use it all the time, and I think more and more it should be really a first line treatment for primary open angle glaucoma and variants. For primary angle closure glaucoma, we also have another laser procedure called iridotomy, which is where we use a similar sort of laser to basically cut a small hole through the iris muscle to allow an alternative route for fluid to drain. Going on to the in-theatre forms of laser now. Now, cyclodiode and micropulse laser is both a form of laser that does impact on the inflow. So in general, this is something that's done under local anesthetic and takes around about 10 minutes or so to do. And there is a probe that touches the outside of the eye that transmits energy through to the ciliary processes, and in effect it kills off some of the ciliary processes, and it can lower the pressure that way, and it can be very effective at doing so. That's all I'll talk about laser now, just for the relevance of the talk. It's mainly focusing on surgical techniques. Now, not to be ignored is cataract surgery. Cataract surgery for a long time has been known to reduce the eye pressure in lots of people by a bit, and that is about as much of a guarantee as you can get in terms of whether it will work for you to reduce the pressure, and we don't really know how long it will work for, but there's a tendency for that effect to wear off at around about a year or so. The way that it works is probably twofold. You can see that same picture of the cross section there. What I've done there with the green sliver is I've shown you the proportional difference of what a plastic lens is like when we've put the artificial lens from cataract surgery. So it creates more space for the aqueous fluid to sit, and it probably improves some sites of resistance as well. The effect tends to be greatest for angle closure glaucoma, and part of the reason of that is in these patients, the lens is pushing the iris forwards, which is closing the angle. So if you take the bulky lens out and replace it with the artificial lens, then the iris can sit back and the fluid has more access to the drainage system to work. Next, I'll talk about minimally invasive glaucoma surgery. And this is becoming more and more a broad topic because more and more devices are available for use across the country and across the world. So in general, the principles of minimally invasive glaucoma surgery is it's fairly quick to perform, and most of them it's around 10 minutes or so. It tends to be safer than traditional glaucoma surgery, and by that I mean trabeculectomy surgery and aqueous shunt surgery, which I'll talk a little bit about soon. It can reduce the drop burden, and by that I mean it can take people off 1 or 2 drops, which is important for people who have lots of drop allergies, or it can delay the need for more invasive surgery. It is not, and in current iterations, is not equivalent to a trabeculectomy in terms of pressure lowering or aqueous shunt surgery. Excuse me. It's often combined with cataract surgery as well. So you might have cataract surgery plus MIGS, cataract surgery plus micro stent of one iteration or another. The reason it doesn't decrease the pressure as much as traditional surgery is you tend to bypass 1 or 2 of the resistant sites, but not everything. And also you still have that that backflow from the venous pressure that we were talking about before. Now, very quickly it can get very complicated here, and I've got some images to show you this. It's too difficult really to go into any specific type, but if anyone's got any questions about specific types, I will answer them to the best of my ability. I have some experience with some of these devices, and a lot of that was from my time working in Moorfields, and I will try my best to answer those things. Essentially, you can put a stent in through the trabecular meshwork and into the canal. You can just incise or cut through the trabecular meshwork to the canal. There are a variety of different micro tubes that can be placed into the front filled chamber and exit the eye in different locations, which covers the microtube and the suprachoroidal stent. And you can also damage those ciliary processes again, so you can affect the inflow. And this procedure, which is a bit of a tongue twister, endocyclophotocoagulation, I managed to say it there, so that was quite good. The idea there is there's a probe that goes inside the eye, and you directly visualize the ciliary processes, and you visualize those shrinking with as a reaction to the laser. Photocoagulation there just means laser. So let's just focus on these subtypes now, and this is just so you can really see what some of these devices look like. So for example, I use the Hydra stent, and I have experience with the eye stents. You'll notice those 2 yellow stents at the edges there on the left and the right side. If you look carefully, they actually drain into slightly different areas. So one of them drains to close to external of the eye but covered by the skin layer, and one is a deeper stent. The CyPass stent, I don't know if anyone's had this, but it's been withdrawn from the market, so it's not readily used now. And I've got another picture here that just shows the many different types of tools that can incise or cut through the trabecular meshwork, enabling the fluid direct access to the Schlemm's canal. Now I'll talk a little bit more about traditional glaucoma surgery, first of all with trabeculectomy surgery. So this has been around for just over 50 years now, and various iterations and improvements in terms of safety and efficacy. It works well, and I do this operation on a weekly basis. It bypasses all of the potential sites of resistance, so it tends to get lower eye pressures than any procedure that it exists. If you've spoken to your specialist about this, they'll describe that it creates a valve or a trapdoor using the wall of the eye. So I mentioned before that the coverings of the eye are quite stiff and don't stretch. So the ideal structures to create a one-way valve system to allow the fluid to escape the eye but not flow back into it. Very importantly, and I'll talk more about this in a second, is that with trabeculectomy surgery, the operation is just the first step. The next few weeks following the operation are probably more vital than the method and the outcome at the very end of surgery on the surgical table. So this is a graphic just showing how, if you follow that blue dotted line, how cutting through the wall of the eye, we can create a fistula or a false passage that can allow that aqueous fluid to drain through. You may have heard your specialists talk about a bleb, and what they mean there is this fluid reservoir that's formed underneath the skin coatings of the eye. So in general, there are two layers of sutures, both at the level of the flap itself, the trapdoor itself, and these tend to be adjustable and or removable, either by laser treatment or by physically removing them at the microscope. This can be done in the clinic setting, and I'll touch on that just in a second. The second layer of sutures are at the level of the skin layer, so the covering on top of this. In very simple terms, this is it. And in terms of complexity of surgery, it doesn't get much more complicated than that for the nuts and bolts of the surgery. The thing that's very, very tricky for both myself as the specialist and you as the patient or relative is that the individual healing response of that eye to that operation tends to cause sealing together of the structures of the eye where you've created that valve. So we try and circumvent that by, at the time of surgery, we use anti-scarring medicines, and we put patients on lots of drops. For example, my regime would be to use a steroid drop every waking hour for a month, which is obviously it's quite a lot. The reason for that is, unusually for a type of surgery, is we don't want the eye to heal specifically in that location where we've created the false passage, where we've created the valve. This is dissimilar to basically any other type of surgery. You know, you have a hip joint. What you want is a hip joint replaced. What you want is you want the hip to heal around as quickly as possible and the patient to mobilize as quickly as possible. With this type of surgery, scar tissue is the enemy. So if we can see inflammation over the first few weeks, or if we can see the pressure rise as a consequence of the scar tissue forming, your specialist will make adjustments. So they will remove stitches. They will potentially, you know, inject medications at the slit lamp, at the microscope. And that is very much within the realms of normal for this procedure. So, so trabeculectomy, you know, things you need to know. Before the surgery, typically people continue all of the drops. Occasionally, the drops are reduced and they're replaced with alternatives. But typically for most people, you continue all of your drops unless your specialist tells you otherwise. And it's very, very important to go through any questions with your specialist, and they should take a reasonable amount of time with you in clinic to go through all of the ins and outs. In terms of the surgery itself, it tends to be day case surgery. It can be under you know, local or general anesthetic. I typically do this under a local anesthetic, and normally we're done and dusted within 60 minutes. As I said before, we use anti-scarring medication at the time. These are medications that initially were derived for cancer treatments, but they work very, very well if given in a bolus dose at the time of surgery to prevent some of the scarring process. Typically, you'll have a pad on the eye afterwards, and you'll be advised to keep that on until the day after, at which point you can take the pad away, but you'll have a hard see-through plastic shield that you'll be advised to use at night for 2 to 4 weeks. The glaucoma drops in the operated eye stop after the surgery, but as I said before, you'll have frequent post-operative drops. So you have antibiotic drops, and my regime for this is typically 4 times a day, and you will have steroid drops, which are very, very frequent, and it varies a little bit from specialist to specialist, but I do this, I use these hourly. I'll just try and speed up slightly because I'm getting towards half an hour and I would like some time for questions. This is typically what an eye can look like early after trabeculectomy. Most of the action of the surgery happens in part of the eye that's covered by the upper eyelid. So in both of these images, you can see that the patients are looking down and someone is pulling their eyelid upwards. Many people just see a white eye afterwards, but the eye, you can expect the eye to be a bit red and a bit bloodshot. The vision can be blurry, so it can be worse initially after the trabeculectomy, and it can be painful, it can be irritating, it can be dry, it can be achy, and it's important when you go into the surgery to know that, really. I've already spoken about the rationale for the weekly review there. Later on, the redness quietens down. It's more easily visible to see the drainage bleb. The medicines are typically weaned down after about a month and the adjustments are less likely. And steadily, the gap is increased between review and the vision begins to stabilize. It can take 3 to possibly 6 months, but typically by around 12 weeks or 3 months, the vision is stabilized. Additional points, the surgery generally goes well, success rates around 85 to 90%. But as I said, even a smooth course involves lots of visits and interventions. You need to expect interventions in clinic at the slit lamp. Around 5 to 10%, either in the first month or after, may need to go back to theatre for either low pressure, high pressure, to repair leaks or to undo some of the scarring process. I'll talk now about aqueous shunt surgery, or commonly known as tube surgery, which is how I generally refer to it. I didn't point out in the last, when I was talking about trabeculectomy, but Glaucoma UK supply a very comprehensive guide for this that's freely available for PDF download. And your specialist may well, I keep these in my office, so I can hand them out to patients and we can go through these things together and with relatives. So aqueous shunt surgery in general, it's reserved for complex glaucoma or for previous failed surgery. So if you're in that 10 to 15% where the surgery's not gone so well in terms of a trabeculectomy, your specialist may talk to you about tube surgery. It uses a small silicone tube to drain fluid from inside the eye to the outside of the eye, again covered by the skin coatings. Very important point here is it's less dependent on scarring. So the attendances afterwards are fewer than for trabeculectomy, and the interventions in the first few weeks are fewer as well. Depending on the type of tube, it can require a second in-theatre adjustment as part of the standard treatment. So for example, I'll show you 2 pictures of the tubes here. On the left, we have something that's known as the Ahmed valve. That has an inbuilt valve that prevents the eye going too soft or the eye pressure going too low afterwards. But I tend to use the tube that's on the right-hand side, which is the Barvelt implant. There's no valve in this. So typically when we perform this operation, you'll see on the right-hand side, we put a thick part of suture material down the tube. And again, this is covered by the skin coatings at the end. But this will often need to be removed to be able to get the pressure low enough. Essentially, if we just put the tube in initially without this, the pressure would go to 0, and that causes much more rapid visual decline than if the pressure was high at 30 or 40 or 25 or something like this. So essentially, the plate is sutured down, and the tube is normally covered by donor graft material. And it's important to talk to your specialist about the type of material that they use for this if you have any concerns about it. But it tends to be material that's either come from the tissue bank that's been checked for every possible transmissible disease, or it comes as what I use, which is irradiated pericardium. So it's tissue from the heart wall that people have donated, that covers the tube and prevents the tube from eroding through the more loose skin layers, because that can increase the risk of infection afterwards. Things you need to know, very similar to trabeculectomy. Continue all the drops and go through any questions with your specialist. The surgery itself can be local or general. I typically prefer to do this under general anesthesia, and it takes a little bit longer to do, but you still come out with a pad on the eye afterwards, and the plastic shield instruction's the same. You would stop the glaucoma drops again, and you tend to have quite frequent post-operative drops. The appearance afterwards is, again, you can only normally see what happens by looking down and lifting the eyelid. These little tubes are transparent, so if you look at yourself in the mirror, you can't tell it's there. You really need a close-up, high-quality image like has been taken from these microscopes. As I alluded to before, the review's less frequent than for trabeculectomy. You may still need medicine given at the slit lamp, or the stitches adjusted or removed. And again, it can leave the vision blurrier initially, and it can be painful or uncomfortable. Importantly, with this type of surgery is, as the eye is healing, which we actually want to happen in this type of surgery, as opposed to the trabeculectomy surgery, the pressure can slowly build up. So it's not unusual for me to explain this to the patients and say, actually, we'll do the surgery, and over the first 12 weeks or so, the pressure may build up to the extent where you might need all of the same drops back again, or even more drops, before we can get you back to surgery and remove the little stitch down the tube. And it's that point that we'll get to a level of pressure control. Again, a little bit later on, the redness subsides, and the vision begins to stabilize. So additional points. In general, the surgery goes well. Success rates marginally less for tube surgery than for trabeculectomy surgery. Again, even a smooth course involves lots of visits and often a second trip to theatre. And around 5% will need to go back to theatre within the first month for high or for low eye pressure. So comparing these two, there's lots of similarities really between these two operations in terms of the patient experience. Most studies report slightly lower pressures with trabeculectomy, but higher complication rates. But there's lots of inconsistencies in the studies. Essentially, your specialist will go through the reasons why your eye really needs the trabeculectomy or the aqueous shunt surgery. And I've just listed some general indications for why trabeculectomy may be preferred first, or aqueous shunt surgery may be preferred first. But you'll need to discuss with your specialist in your own circumstance. So I'll just go through some of these questions now that we had before. So my eyes feel fine. Do you really need to operate? Often, yes. And that's part of my challenge, because glaucoma is often asymptomatic, and I'm often listing for operations whilst the patient's asymptomatic. If a patient is asking me that question at the point where we're about to list for theatre, though, I've not done my job properly. So it's important that you say to your specialist, hang on a second, what do you mean? And they should take time to explain that to you. Will it cure me? I answered this before. There is no cure for glaucoma. We can only slow it down, but these methods tend to slow it down extremely well. This is an important one. So I typically don't stop any blood thinners. So blood thinners like warfarin, clopidogrel, apixaban, rivaroxaban. I typically don't stop these, but lots of glaucoma surgeons do. So it's important that they will normally go through all these things with you if that's necessary. Can I wear my contact lenses after surgery? The answer to that's yes, but normally you need at least a month off them. So you need to make sure you have glasses that are up to date, and you need to wait until you've spoken to your specialist before wearing them. When can I go back to work? It's very dependent on the type of job that you do. If it's a job that requires any kind of vigorous exercise or heavy lifting, you typically need a minimum of 2 weeks off. And you can ask your specialist for sick notes for that, which they should supply for you. The same is true for exercise. When people are on, if swimming is what you like to do, I typically say a month off whilst you're on the drops. And it's very, very dependent. So you need to discuss your own circumstance with your specialist. I've just had surgery. Can I still use my dry eye drops? The answer to that is definitely yes. Because otherwise the post-operative course could be worse for you. I would just advise you to get a fresh bottle before you to start afterwards, because you don't want to introduce infection into the eye. Do I still take glaucoma drops after the surgery? The answer to that is maybe. With some of the MIGS procedures, some specialists will keep patients on some of their drops. And certainly the eye that's not operated on, you need to just continue what you were doing the previous day. But in general, the glaucoma drops stop on the day of surgery for trabeculectomy and aqueous shunts. Will this surgery cause me to get a cataract? Unfortunately, the answer is probably yes for this. Both trabeculectomy and aqueous shunt surgery can induce cataract quicker than it would have appeared naturally. My take on this is, and some specialists will always say to you, well, we'll take the cataract out first, even if there's not much cataract, and then we'll do the other bit. My take on it is I will do the thing that is the greatest priority. So if I think there's a lot of cataract there, then I'll do the cataract surgery. If I think there is progressing glaucoma there, then I will do the glaucoma surgery. And I tend to never combine the two, although lots of specialists do combine the two with reasonable results. In summary, in glaucoma, not enough fluid can escape from the eye. The eye pressure rises, which essentially just squashes the optic nerve and kills part of the optic nerve off. Glaucoma surgery aims to address this, and cataract surgery can help, especially in angle closure. MIGS can reduce the drop burden or prevent or delay more invasive techniques. Trabeculectomy and aqueous shunt surgery are more involved and more invasive with more risks, but they're much, much more effective for pressure control than other types of surgery. And finally, probably the most important of everything that I've spoken about, please always remember to talk through any concerns with your specialist. And thank you very much. And I will stop sharing now and gladly take any questions.
That's fantastic. Thank you, David, very much for that informative and talk there. We have got a lot of questions coming through, so we'll do our best to get through them all, but I'll remind you that at the end of the session, I'll put up our helpline details, our phone number and email address. So if we don't get round to your question, please do get in touch with us, and so we can still help you with your question. So let's get started. The first question I have here is 60-year-old male with an IOP of 10 in both eyes using drops, but doctor is still recommending trabeculectomy. Excuse me.
Yeah, that one. Yeah.
Why would that be the case if drops are controlling the pressure? Okay.
Yeah, so I suspect in your case, and obviously I've only got a little bit of the story here, but I suspect in your case, you're describing a variant of glaucoma called normal tension glaucoma, or you still have progression at those quite low pressures. So there are a couple of things to bear in mind whenever you have a pressure check. The first thing is that that there's diurnal variation, so the pressure goes up and down every hour. And it may be that your peak pressures are higher than this. And some specialists actually check this. I typically don't. If I see progression at a level of 10, occasionally, you will need a trabeculectomy. And when I was in Moorfields, I spent time with one of the world leaders really in normal tension glaucoma or low tension glaucoma, Debbie Kamal. And she would often, we would often be listing patients with a pressure of 10 or 11. And we would achieve a pressure of sometimes 4, 5, or 6 afterwards, and the vision being crystal clear and really stopping the progression in its tracks as much as we can. So it is possible that that's what your specialist is describing there for you, because they are aware that trabeculectomy can be effective for reducing this further. The second thing why trabeculectomy can be useful in your situation is trabeculectomy tends to flatten out any peaks over the course of the day. So if you have a pressure of 10 and it either goes up or down and goes back to 10 again or higher, that fluctuation in pressure can be damaging. Whereas after trabeculectomy, the pressure tends to be more stable, which tends to be less damaging on the nerve. So hopefully I've answered that question okay for you.
Great, thank you. Next one, recently diagnosed with glaucoma. I was told eye drops are the gold standard and they have reduced the pressure, but the consultant is unwilling to talk about other options. So are drops the gold standard, and how soon following the start of treatment might I be talking about other options, or should I just accept that drops are working and stick with them?
So that's it's a really common question, that, and I often see people who've been seen by other colleagues who sort of ask the same sort of things. The in terms of a gold standard, I suppose drops initially are. If you were to look at the NICE guidelines, which is sort of the national guidelines for primary open angle glaucoma and variants, which includes things like pseudoexfoliation and pigment dispersion, or for simple ocular hypertension, traditionally drops have been first line. The only thing is there has been an addendum recently to the NICE glaucoma guidelines, in that specialists should consider SLT, which I alluded to briefly, as equally first line. And this was on the basis of a trial called the LIGHT trial, which is LIGHT, which was published in a variety of places, including the Observer, and you can get the results for that, which showed that for a patient who had had no treatment, if they were to have a single SLT treatment, there is 80% of the people in that trial had acceptably lower pressure without any further drops or surgery within 3 years. So, and there's lots more data out of that, but for me, I tend to offer people drops or SLT. The only patients I don't offer SLT to would be patients who have a starting pressure of less than 20, because SLT tends to be less effective in that situation. So hopefully that, I think I've answered the question there, hopefully.
Okay, next question we have, and you did touch on it in the presentation there. Could you give guidance on what we're allowed to do exercise-wise post-trabeculectomy? Like, I'm having an issue with that word today. You think I'd
yeah, trab, that's what we call it. Yeah.
In terms of a scale of weeks, months, and is swimming under possible using goggles?
Yeah, so the rationale for me saying people to stop swimming, so it's quite, and I appreciate that I make quite an impact on an individual's life when I do this surgery and say, oh, you can't do this, you can't do that. The rationale for stopping people swimming for about a month afterwards is, for the first month, I'm giving people hourly steroid drops, and that weakens the immune system locally. So if you swim, particularly if you open water swim, that increases the risk of quite harmful organisms causing an infection, which can then really cause issues for not just for the trabeculectomy, but for the eye. So that's the main reason for swimming. I appreciate what you're saying about, you know, wearing goggles and, you know, stopping any of the water getting in, but realistically, you know, when I swim, I struggle to keep all of the water out of the goggles, and so as such, I just have a blanket rule for that particular thing. Yeah, but it's something to have a chat with your specialist about. But it, you know, if you were to say to me, well, oh, please, can I just do some lengths with my head above the water after 2 weeks, then, you know, I may begrudgingly agree to that. But it's all a slight balance of risks when we don't really have evidence for these sorts of things. We're just educated guessing on the basis of what we know happens. So I know that the steroids reduce the immune system a bit. And I just think I really don't want any of my patients to get a really bad infection in the first few weeks after a trab. It's bad enough anyway, you know, with coming to the hospital all the time and taking lots of drops to then be faced with other issues.
Okay, great. Thanks for that one. Next question. I have normal tension glaucoma. Is there any possible contributory factors causing damage to the optic nerve, i.e. poor circulation?
Yeah, so this, I suppose this question's less focused on surgery specifically, but normal tension glaucoma comprises about a third of open angle glaucoma, which is the most common form of glaucoma. And you know, it's definitely possible that the circulations can, you know, contributing to that. My typical approach to it is I begin to treat it just exactly the same as primary open angle glaucoma, except, as I said, I don't tend to offer SLT for it initially. So I'd offer eye drops, and if I'm able to get significant percentage reduction in pressure and then monitor and see no progression, then I take that as acceptable. There is quite a lot of detail that you can go into for investigating normal tension glaucoma. You know, for example, people with migraines have a tendency to have normal tension glaucoma, or vice versa. You know, people who have normal tension glaucoma have a tendency to have migraines. People who have normal tension glaucoma have a tendency to have Raynaud's or poor circulation to the hands or feet in very cold weather. They have a tendency to have lower blood pressure. And one of the things that's worth looking at, if you say, for example, I was to do that and start a patient on eye drops and reduce the pressure and get the pressure very low to around 10, like this gentleman was talking about, mentioned on the questions earlier, and still was able to see progression, one of the things that I would then look at would be blood pressure medication. And I would potentially negotiate with a GP about changing the timing of blood pressure medications, because particularly blood pressure medications at night reduce blood pressure potentially to harmful levels during the night when the blood pressure tends to be at its lowest anyway, which can then have an impact on circulation at the optic nerve. So there's definitely a lot of detail you can go into, but I would say for the vast majority of my normal tension glaucoma patients, they're treated fairly similarly to the patients who have higher pressure variants of glaucoma.
Okay, great. We've still got 12 questions here, so we'll...
Yeah, well, I'm happy to keep going.
Okay, excellent. With medication-induced glaucoma, is it still lifelong once an aqueous shunt is put in place?
So with medication-induced glaucoma, I would probably need might need slightly more information here. Now, the most common medication-induced glaucoma is steroid-induced glaucoma. So I suppose I'll answer it on that basis. And it's difficult without knowing all of the specifics, but it's perhaps hard to go into that level of detail in this scenario anyway. Lots of people have conditions that mean they need to take lifelong steroids, and lots of people have pressure rises subsequent to subsequent to the initiation of steroids. And it's a bit of a strange topic, because things happen like for example, after an aqueous shunt operation, you have some steroid eye drops, and the pressure goes up in the other eye, and you think, well, there's no known sort of negative feedback mechanism in the brain that could cause that as secondary to the steroids, and the quantity of steroid that would be circulating throughout your body to then travel to the circulation in the eye and have that effect is extremely small. In answer to the question, will the question's just disappeared here. Let me just try and find the specifics again. Sorry. Or is it further up towards the top? The question was based on aqueous shunt surgery and whether you would still need medication, I think, wasn't it?
Yeah, that's right. With medication-induced glaucoma, is it still lifelong once aqueous shunt is put in place?
Yeah, so sometimes, unfortunately, it can be. Sometimes the tube does not completely control. So the 75 to 80% of patients who manage to have control just with the surgery, you might just not fit into that, and it's quite, it's I would say reasonably common for people who require a tube operation to need at least one of their medications back on to help control the pressure fully. I've certainly got a few patients that have needed a second tube, and when I was at Moorfields, you're seeing the complex of the complex, and there were a few patients that I put a third tube in. So it's not necessarily the whole story when you have your tube surgery, although it can feel as if it's at the time as if this is the one thing that's going to improve it. It's just the thing that's got the best chance of lifelong improving it. So hopefully that answers the question as fully as I can, really. Oh, I think you've gone on mute, Hannah.
Apologies, thank you.
That's the right one.
I have a question here. I have a trab in my right eye. My consultant has suggested a stent in my left eye. I have an appointment for laser on that eye this week. Should I go ahead with this?
So yeah, this is it's kind of a little bit too niche without knowing all the full details here. There's plenty of people who I see who don't necessarily need a trab in both eyes. They might have one eye that's, most of the time the glaucoma is asymmetric, so it's more severe in one eye than the other eye. So there's plenty of patients of mine who have a trab in one eye, and then the other eye might just need drops, or it might need drops and laser, or it might need drops and laser and stent. It's hard to give you sort of a yes no answer for this. The answer on the basis of the information I've got is quite possible. But on the day when you're having the laser, if you're not completely happy that it's been discussed with you, which is what it sounds like on the basis that you've mentioned it, I would say just please take me through why we're doing this differently for my left eye. And they should, they're duty bound really to go through these things. Just everyone's busy, and COVID's happening, everyone's panicked, and all of these sorts of things. So it's and you have to remember as well, the doctors and the nurses who are seeing you, that they've been in and out and exposed to any number of people, so they can sometimes miss the point, which for me is all the overriding principle is always, communicate everything to the patient. I want the patient really to understand it more or less as I understand it before we decide together to go ahead with something. I don't ever want to be really saying to people, you need this, sign here, please. It's just not the way that we should be practicing medicine. So just make sure that they go through it with you.
Great, thank you. We are actually at 8 o'clock now, so if we just do a couple of more questions before coming to an end. I'm not get a chance to go through all of your questions, but again, if you stay till the end, I'll give all the details for how you can contact us and have your questions answered. So just quickly, one here: is it possible to repeat a trab if the previous one has failed?
Yeah, so there's a handful of things that you can do for a trab if it's failed. So the first thing that might be suggested is a needling procedure. The full term for that really is needle revision, and the idea is that we, as gruesome as it can sound, we're using something sharp to divide some of the scar tissue away and trying to revive the surgery that's there. Some of our patients have had surgery elsewhere some time ago, or had surgery by one of my colleagues some time ago, and they've been referred to me, and they've had a trab that's failed. And sometimes I say, well, before we undertake tube surgery, we may be able to either revise this or redo the procedure just next to where you've had it done. So how I describe it to people is, I don't know which one of those two that I will do, because some of it you can only see when you're looking down the operating microscope, because you see the eye in a slightly different way once you've removed away some of the skin layers. So yeah, it's definitely possible to revise, and it's definitely possible to repeat the procedure in the same eye. Yeah, and I do that from time to time.
Lovely, thank you. And we're going to do our final question of the evening, I'm afraid. Some sources, such as the NHS Choices website, suggest that a trab is quite a rare surgery, and a lot of people, the first sort of line is always seems to be eye drops. So if you were diagnosed with glaucoma this year, how likely is it that you would have to have some sort of surgery within your lifetime?
Yeah, it's a really interesting question, actually. I don't know the kind of percentages for that. Common and rare things are only common and rare to different portions of people. So there's plenty of people who I see with rare types of glaucoma, and I do trabs pretty much every week. So it's not rare to me. But obviously, any individual might only have this surgery once, and they might not know anyone unless they talk to someone in Glaucoma UK or at various meetings. They might never meet another person that's had the same sort of thing, and that's why it's very hard for a patient, because a lot of patients have had, oh, my wife has had cataract surgery, so I know, or my neighbor has had this, or my friend has had this. So it really, the crux of this is how advanced the glaucoma is at the time that you present to the hospital. So traditionally, people with, you know, low community surveillance, people would present quite advanced in both eyes, so they lost quite a lot of vision, and actually that makes the operation riskier. With an awareness that family history contributes to glaucoma, with improved community surveillance by the optometrists, that does help identify glaucoma much sooner. There's a study ongoing at the moment. It's called the TAGS trial, that's run by a chap in Nottingham, and he is looking specifically at people who present with advanced glaucoma, because traditionally people are always given drops first. But it's probably not the best thing to do if you present with advanced glaucoma. It's probably better to say, actually, let's just get this sorted once and for all if we can with an operation like a trab. So for those people, primary trabeculectomy is probably the way to go. You'll still be given some eye drops initially, but primary trabeculectomy is probably the way to go. However, if you're presenting with, could this be glaucoma? Could this be very early glaucoma? The chances of you needing, you know, losing functional vision or needing an operation for it is very low. You know, most people who go to the glaucoma clinic don't. They attend for the rest of their lives and have eye drops, and sometimes have cataract surgery, and that's about as dramatic as it gets for most people, and sometimes laser treatments. But in terms of a likelihood, if you're looking for me to quantify that, I can't really give an absolute figure on that. But it depends how bad it is when you present.
Okay, that's brilliant. Thank you, David. We're going to draw to a close now. Excuse me. So I just want to thank you all for joining us this evening. I'm sorry we didn't have the time to get through all your questions. You'll see now it's popped up on the screen again is our final poll. If you could take a couple of minutes just to fill that out for us. I will be putting on the screen in a couple of minutes our phone number and our helpline email address. So please do send your questions into us, and we will get back to you. Also, I know there's been a few people asking whether you'll be able to see the presentation again. This has gone out on Facebook Live, so all of the whole recording will be on Facebook, our Facebook page, that you can go and look back at any time you like. And if you can email us a request, we can send you out copies of slides as well. I want to thank everybody who's joined us on Facebook as well. Again, I'm sorry we've not been able to get through to all of your questions this evening. David, thank you so much for joining us for the second time, and for taking us through that really useful, really informative presentation, and then answering our questions in so much depth. That's been really, really useful. I'm sure everyone's benefited from that.
Okay. Thanks for having me.
Thank you. So I'm just going to read out those contact details, and then we'll take the poll down and put them up on the screen as well for a couple of minutes before we end the session. So our helpline number is 01233 648170. And you can also contact us by email, which is helpline@glaucoma.uk. That's helpline@glaucoma.uk. Our helpline is manned Monday to Friday, 9:30 till 5. So you will be able to contact us that way. And I shall now just put those last details on the screen so that well, I will in a moment. Just bear with me so that you can see all of those. There we go. So our helpline number and our email address. Okay, there we go. So I'll leave that on the screen for a couple of minutes if anyone wants to write it down. Also, obviously, all of our information is on our website, glaucoma.uk. So you can find out all about our next digital support sessions on that web page, and you can register for them, and you can also watch our digital support sessions that we've held over the past few months. Yeah, so again, thank you all for joining us. And yeah, we'll see you again soon.